Bismillah ar-Rahman ar-Rahim. Dear students, Assalamu alaikum. Today we will start the second lecture in the neonatal lecture series. And the title of this lecture is Prematurity. The objectives of these lectures are knowledge the criteria of premature baby, and try to know what are the medical problems related to him. In another way, what are the complications of prematurity and how to manage premature, because prematurity is an important subject and it is a common problem, especially in developing countries. So we need to know these facts about it. There are some definitions related to neonates. When we mention premature baby, means he was delivered or he is delivered less than 37 weeks of gestation. And usually premature babies have low birth weight unless they are large for gestational age. So when we mention low birth weight, it means the body weight or birth weight is less than 2.5 kg. And those groups of babies are subdivided into three groups. Preterm, who is appropriate for gestational age, means the weight is proportional for his gestational age. Again, preterm and who is small for gestational age, the body weight is less than expected for his age. And term baby, but the body weight is not proportional to gestational age, and we call him small for gestational age. Very low birth weight baby, when the birth weight is less than 1.5 kg. Immature or extremely low birth weight, less than 750 gram, and previable when the body weight is less than 500 gram or gestational age is less than 22 weeks of gestation. What are the physical criteria of a premature baby? How does premature baby look to us? As the premature baby, when he is very preterm, have thin and dark red skin. The skin is immature, so it is red in color. It reflects the vascularity under it. And the no palpable breast tissue. We cannot palpate breast tissue, especially in very preterm infants. And there is soft cartilage in the ears, so the ears will be shapeless and soft. Genitalia help us in assessment of gestational age. In male, the testes have not yet descended to the scrotum, and in female, the labia majora are separated and labia minora are protruded. While in full term, if you remember in the previous lecture, the labia majora cover the labia minora. Regarding their position, the preterm baby is lying. When he is supine position, there is extension rather than flexion because of a decrease in his body tone. This picture shows this is immature hair involving the face called lanigo hair. This occurred in premature baby. This picture, which was previously seen by you in the previous lecture of preterm baby, there is little subcutaneous fat. He looks thin. See his position. There is extension of lower limbs rather than flexion because of decrease in the body weight. There is decrease in the cartilage of the ear, and the breast tissue is not palpable. This is a picture of full-term baby who is small for gestational age. we will take it in separate lecture, but I put his picture here in order to differentiate between this baby and premature baby. The skin is mature and looks dry. The cartilage of the ear is mature and the breast is mature, the breast bud. We are reaching now to the second aim of this lecture. We try to know what are the medical problems of preterm infants. What are the complications of prematurity? Most of those babies are in need for resuscitation at birth. This is a picture, this is oxygen, this is the site at which cardiac compression is done when needed. Look to this picture. This is a ward of premature of neonatal unit. There are a lot of instruments. There is ventilator, there is monitors, a lot of drugs, a lot of IV line. So they need more equipment than other children. Another complications involve the respiratory system, and this is the most important complication, respiratory distress syndrome, which is mean deficiency of surfactant. Deficiency of this factor lead to alveolar collapse, then inadequate gas exchange, and more premature associated with more incidence of RDS. And they need, of course, exogenous surfactant therapy. You will take a separate lecture about premature with RDS, respiratory distress syndrome. This is a picture shows to us X-ray of respiratory distress syndrome. Another complication related to respiratory system is pneumothorax. Pneumothorax because of ear leak in the pleural cavity had occurred in 20% of infants who are ventilated for RDS. Here ventilation is important in this group of neonate because of immaturity of lung, especially very low birth weight may need ventilation and intubation means. Another complication of respiratory type, apnea and bradycardia, especially in very low birth weight in neonates who are less than 1.5 kg. This is a picture of a neonate who need, this is a tube, this is laryngoscope to introduce intubation. Look to him, he is cyanosed because of respiratory distress syndrome. This is again the same picture but a larger size, showing to us the infant with RDS and intubation done for him. Other complications that may occur in prematurity are cardiac complications in form of hypotension, or they may have patent ductus arteriosus, which is common in neonates who have respiratory distress syndrome. PDA may be associated with some symptoms or sometimes asymptomatic. If there are symptoms, they will be in form of apnea, bradycardia, and we will find difficulty in weaning those infants from artificial ventilation. It means they need more duration of oxygen than other group who have RDS but without patent ductus arteriosus. Also, they have bounded pulses. This is picture of preterm with some complication related to heart. Look to the stethoscope, try to detect the heart rate and murmur if present. This is a picture again. The hand was put in the lower sternal border to do cardiac compression when they develop bradycardia. other complication which is very important that may occur to this group, the problem in temperature control, because they have larger surface area in relation to their body weight. The skin is thin, they are unable to shiver, and usually they nurse naked without clothes, as you see in this picture. So this exposes the neonate to develop hypothermia. Another problem is fluid balance, difficulty in fluid balance. This slide shows you the requirement of fluid, 60 ml per kg in the first day, then increased to 30 ml per kg per day, up to 180 at the end of first week. Another problem, which is again important and significant, is nutrition. The requirement for nutrition in a premature baby is more than other group of neonate, because the rate of growth is rapid, more rapid than others. For example, preterm baby, 28 weeks of gestation, doubles his body weight in 6 weeks and triples in 12 weeks. If we compare him to term baby, this term baby will double the birth weight in 4.5 months and triples in a year. So the rate of growth of premature is more rapid than full term. So we consider this point when we want to assess the nutrition, especially for those babies who are small, who are early preterm. While older preterm, 35 weeks, 36 weeks, they are mature enough to suck and swallow. The problem with small premature is sucking and swallowing. And also there is no coordination between sucking and swallowing. So they cannot feed directly from the breast as large preterm, 35 and 36 weeks. They need to introduce their feed via an oral or nasogastric tube. This is the method of feeding. But if you ask what is the type of feeding, of course the answer will be breast milk is preferable for all neonates, whether premature or full term, even very low birth weight. It is preferable to give them breast milk. If there is failure to gain weight or there are some problems with breastfeeding, there are special infant formulas for low birth weight infants. And if the infant is sick and was admitted for intravenous fluid, he cannot feed orally, there is what we call it parental nutrition. This picture shows to us the method of feeding low birth weight from the breast. This mother holds her baby in the underarm position, the same side. Here, the mother holds her baby with the arm opposite the breast. Both those methods are useful for infants who have low birth weight, less than 2.5 kg. This is another method of feeding low birth weight from a cup. But not like in older infant. We just put a cup and near the mouth and the infant will take it by his tongue in order to avoid aspiration. If the mother has sick baby admitted to the neonatal unit, we advise her to express the breast milk. This will be given later to her infant, and these are pictures of procedures of doing expression of breast milk. We are still talking about the complications of prematurity and metabolic complications like hypoglycemia, hypocalcemia, electrolyte imbalance, and osteopenia of prematurity are among the common problems in the premature baby. Another complication is infection, and this infection either occur in the early neonatal period اللي هي first 7 days of life or may occur later on nosocomial from the environment. If it occurs early, of course it will be taken from the mother during maternal birth canal. Another complication which is serious is intracranial lesions. And examples of intracranial lesion is periventricular hemorrhage, which occur in 25% of very low birth weight baby, dilatation of ventricles, hydrocephalus, and ischemic lesions of periventricular leukomalacia, because those group of infants cannot tolerate hypoxia as in older infant. This picture shows to us bisected brain with intracranial hemorrhage. Look to the hemorrhage in this area. And they are more liable to have a bleeding, this group of baby. This is the hemorrhage. Another complication is called necrotizing enterocolitis, which is a serious illness, occur in first few weeks. The cause is ischemia of the bowel wall, may be accelerated by feeding with milk, and the clinical presentation of this problem, vomiting and abdominal distension. Another complication is retinopathy of prematurity, because the developing blood vessels will be affected. What occur is vascular proliferation, which lead to retinal detachment. This picture shows abdomen which is open with intestinal hemorrhage. This after death of those babies, they try to know the cause of death. Other complication is iatrogenic, which is induced by doctors or nurses. For example, they aspirate amount of blood larger than what should be aspirated, and this may lead to anemia. For example, delay in oxygen giving, wrong calculation of fluid. This will result in certain problems and so on. There are many iatrogenic disease occur in this premature baby. And there is a condition called Bronchopulmonary Dysplasia. The clinical presentation of those premature who have this problem, they need prolonged oxygen beyond 28 days of life or beyond 36 weeks of gestation. In another way, we call it a chronic lung disease, especially those infants who develop respiratory distress syndrome. Again, they will need oxygen later on, even if the course of the disease is finished. Another complication is anemia of prematurity. And there are what we call problems following discharge or late complications. The premature will be shorter and thinner than full term, which means the growth may be affected. خاصة إذا كان البريماتور أيضا small for gestational age. They need readmission to the hospital during the first year of life, and this chance of readmission increases fourfold in very low birth weight. يعني كل ما كان الجستيشنال age قليل وكل ما كان البيرث ويت قليل كل ما كان chance of complications كل الcomplication تقريبا اللي قلناها is more. Another complication, they may present with recurrent wheezing in infants with bronchopulmonary dysplasia, but they can be treated with monoclonal antibody to respiratory syncytial virus antigen. This will be given monthly, reduces the hospital admission for those preterm babies. Another complication, because of weakness of the muscle, they may develop inguinal hernia. And there are certain complications called neurodevelopmental problems. Again, long-term complications. Later on, may they come with visual impairment, with hearing loss, cerebral palsy, delayed speech, learning difficulties. They may look normal, but when they are reaching school, they will present with learning difficulty. They may have poor attention span. They may have difficulty with fine motor, and they may develop behavioral disorders. Now we are reaching to the third aim of the lecture. How can we stabilize the condition of this sick baby or baby who is premature less than 34 weeks of gestation? So, what are the lines of management? How can we deal? Of course, they need admission to the neonatal care unit or intensive care unit, and we do some facilities for them. They need additional oxygen, either direct or artificial ventilation, especially when they have RDS, and especially when they are small preterm, less than 34 weeks of gestation. The priority to the respiratory status, then we need for them circulatory support. They may need blood transfusion or saline transfusion or inotropic drugs. So they need monitoring of the heart rate in order to assist the circulation. So monitoring is in form of heart rate, respiratory rate, temperature, and we need to measure their oxygen by pulse oximetry. And also we need to do tension of CO2, not only O2. So they need a blood gases analysis. Other investigations that they need are chest X-ray to diagnose respiratory problems. Usually we should avoid hypothermia. They may need nursing in the incubator, or they may have a radiant warmer according to their size, according to the degree of their body temperature. And they need also antibiotics, and usually they need broad spectrum antibiotic. This neonate is lying in resuscitator, and above his head there is a source of warmer. We're still talking about the steps of management of those sick babies or premature baby, and we should monitor their metabolic state and measure their blood glucose. They are liable to develop hypoglycemia, and they may need intravenous dextrose water. Also, we need to calculate the fluid requirement according to their need and according to their age, according to their weight also. We try to do minimal handling as much as we can, because the procedures are painful. Even, for example, intravenous fluid, cannulation, a lumbar puncture. So this will affect the percentage of oxygen, affect oxygenation, and they may need sedation. So we handling of those baby try to be minimized as much as we can, or even to decrease the chance of infection. In their management, don't forget to share their parents. There will be some time for parents to allow them to see, to touch their babies, and to be kept fully informed. Because when there is separation of baby from his mother, there will be decrease in the maternal-infant bonding relationship. This will affect the breastfeeding, the growth, the development, and there are many sequelae of this problem. So try to involve parents from early admission of those babies to the nursery or to the neonatal care unit. These are pictures of premature baby who need submanipulation, like intubation. This is laryngoscope. We saw this picture previously. Also this examination of the heart. As you observe in these pictures, there are some people around the baby. There is team of workers, not only one, responsible for resuscitation of the baby. One is responsible for intubation, for example. One is responsible for heart, and we may involve a third one. And all those baby who are dealing with a neonate should have experience with nursing or taking care of this group of babies. This is oxygen given by mask. Again, this is a team, and see the precautions, their clothes, their mask, cover their hair, cover their shoes. Everything should be sterile and clean in these units, because they are liable to develop infection more than other units, of course. And this is a procedure also done, expiration of some secretion from the nose. This is oxygen by ambo bag, and this is this picture demonstrates epiglottis when we want to put tube for endotracheal intubation. And thank you. I hope you can guess the difference between premature baby and full-term baby. And in the next lecture, we will talk about other group of baby who is called small for gestational age and large for gestational age. Thank you again.